One part of Medicare costs you $0 a month, and the other one just jumped to $202.90, and most people on the program still can't explain the difference between them. We're going through everything about Part A and Part B today, what each one actually pays for, what they'll cost you in 2026, and the enrollment traps that quietly add thousands of dollars to your bills for the rest of your life. Medicare goes all the way back to July 30th, 1965, when Lyndon B. Johnson signed it into law at the Truman Library in Independence, Missouri. Harry Truman stood right beside him that day and received the very first Medicare card, which felt fitting because Truman had been pushing for national health insurance since The Part B premium at launch came out to $3 a month. Fast forward 60 years, and that same premium now sits at $202.90, while more than 67 million Americans rely on the program. Whether you're approaching 65 or you've already been enrolled for years, the 2026 changes deserve your full attention because the numbers shifted more than usual. Let's get into what each part actually does for you. Part A is hospital insurance, the layer of protection built for high-cost medical events that could financially wreck a family overnight. At the center of Part A sits inpatient hospital coverage. Your semi-private room, meals, nursing care, medications given during the stay, and every medically necessary service gets picked up. For the first 60 days, you owe $0 in coinsurance once you've met the deductible. After that, the daily cost climbs to $434 for days 61 through 90. And if you're still in the hospital past day 90, you start burning through your 60 lifetime reserve days at $868 per day. Those reserve days never reset once they're gone. Skilled nursing facility care also falls under Part A, covering up to 100 days per benefit period, but only when you've had a qualifying 3-day inpatient hospital stay first and entered the facility within 30 days of discharge. Days 1 through 20 cost you nothing out of pocket, while days 21 through 100 carry a $217 daily coinsurance. After day 100, the full cost lands on you. Terminal illness triggers a different Part A benefit called hospice care. When a doctor certifies a life expectancy of 6 months or less, and the patient chooses comfort over curative treatment, Part A picks up nursing services, pain medications, medical equipment, therapy, social work, and grief counseling at nearly zero cost. Home health care rounds out the Part A coverage list, paying for homebound patients who need skilled nursing or therapy under a doctor's plan, up to 100 visits per illness following a qualifying hospital stay. And here's the number that surprises a lot of people when they first hear it. Roughly 99% of beneficiaries pay $0 in monthly Part A premiums. If you or your spouse put in at least 40 quarters of Medicare taxes, which works out to 10 years, the premium disappears entirely. Miss that threshold, and the 2026 premium runs as high as $565 every month. Part B handles medical insurance, and this is the side of Medicare that most people interact with on a regular basis, because it touches almost everything outside the hospital walls. Doctor visits, specialist appointments, outpatient surgery, diagnostic procedures, and lab work all run through Part B. Once you clear the annual deductible of $283 in 2026, Medicare picks up 80%, and you cover the remaining 20% of the approved amount. Where Part B really earns its keep is preventive care, because most preventive services cost you absolutely nothing. No deductible, no coinsurance. That list includes your annual wellness visit, cancer screenings like mammograms and colonoscopies, and lung cancer CT scans, cardiovascular screening every 5 years, diabetes screening, depression screening, bone density tests, glaucoma tests, and tobacco cessation counseling. Flu shots, pneumonia vaccines, COVID vaccines, and hepatitis B vaccines all come at zero cost as well. Part B also reaches into territory that a lot of enrollees never realize exists. Durable medical equipment like wheelchairs, walkers, hospital beds, oxygen equipment, and insulin pumps qualifies at 20% coinsurance after the deductible when a doctor writes the prescription. Mental health coverage has expanded steadily, now including outpatient visits with psychiatrists, psychologists, and clinical social workers, plus licensed marriage and family therapists as of 2024, along with substance use disorder treatment, intensive outpatient programs, and a free annual depression screening. Ambulance services, outpatient physical and occupational therapy, limited chiropractic care, certain outpatient drugs that are injected or infused, kidney dialysis, and second surgical opinions all live under Part B too. Most clinical lab tests carry zero cost to you, with no deductible and no coinsurance for the majority of diagnostic labs, which makes them one of the best deals in the entire program. A few lesser-known benefits round out the Part B picture. Diabetes supplies and self-management training, diagnostic eye exams for conditions like glaucoma and cataracts, diagnostic hearing and balance exams ordered for fall risk, and limited dental work tied to covered procedures all qualify. That dental expansion grew in 2025 to include care needed before kidney dialysis. Now let's get into the money, because 2026 brought cost increases that hit harder than most years. On the Part A side, the inpatient deductible climbed to $1,736 per benefit period, up $60 from 20. Keep in mind that's per benefit period, not per year. Getting admitted, discharged, and readmitted after 60 days means paying that deductible a second time. Every Part A cost-sharing amount rose by roughly 3.5% across the board. Part B tells a bigger story. The standard monthly premium jumped to $202.90, a near 10% increase from the $185 people paid in 2020. The annual deductible rose $26 to $283. CMS pointed out that the premium would have landed about $11 a month higher if regulators hadn't slashed spending on skin substitutes by roughly 90% through a targeted policy change. What makes this sting for a lot of people comes down to simple math. Social Security's cost of living adjustment for 2026 landed at 2.8%, while the Part B premium increase sat close to 10%. For many beneficiaries, the premium hike eats into or entirely wipes out the Social Security raise they received. For those struggling with Medicare costs, Medicare savings programs can help. The Qualified Medicare Beneficiary Program, Specified Low-Income Medicare Beneficiary Program, and Qualified Individual Programs all help pay Part B premiums and other Medicare costs based on income and asset limits. These programs work alongside Extra Help, also called the Low-Income Subsidy, which assists with Medicare Part D prescription drug costs for those who qualify. Higher earners face an additional layer called the Income-Related Monthly Adjustment Amount, known as IRMAA. This surcharge uses a 2-year lookback, which means your 2026 charges are based on your 2024 tax return. Singles who earned under $109,000, or couples filing jointly under $218,000, pay the standard premium and nothing extra. Go above those thresholds and the surcharges escalate quickly. At the top bracket, $500,000 for individuals or $750,000 for joint filers, your total monthly Part B premium reaches $689.90. About 8% of beneficiaries end up paying IRMAA, according to CMS estimates. The part that catches people off guard is how IRMAA works as a cliff rather than a sliding scale, meaning $1 extra of income above a threshold triggers the full surcharge for that entire tier. This section might save you more money than anything else in the video, because enrollment mistakes in Medicare carry penalties that follow you permanently in some cases. Your initial enrollment period opens a 7-month window built around the month you turn 65. Coverage begins 3 months before your birthday month, includes the birthday month itself, and stretches 3 months after. Anyone already collecting Social Security benefits gets auto-enrolled in both Part A and Part B when they hit 65. Everyone else needs to take action and sign up. Missing that window pushes you to the general enrollment period, which runs January 1st through March 31st each year. You can also make changes during the annual election period from October 15th through December 7th for coverage that starts the following year. One bright spot is that since 2023, coverage now kicks in the month after you enroll, instead of forcing you to wait until July, which was the old rule and caused real harm to people who needed care. The most common escape from these deadlines comes through a special enrollment period tied to employer coverage. When you or your spouse carry group health insurance from a current employer with 20 or more employees, delaying Part B enrollment carries no penalty at all. Once that employment or coverage ends, an 8-month enrollment window opens up. But here's the thing that catches people year after year. COBRA does not count as current employer coverage. The enrollment clock starts ticking the day active employment ends, not the day COBRA expires, and that gap has cost countless retirees thousands of dollars. Late penalties work very differently between the two parts. Part A's penalty runs at 10% of the monthly premium and lasts only twice the number of years you were late, then it drops off. Part B's penalty operates on a completely different level of severity. You get hit with a 10% surcharge for every full 12-month period you could have enrolled but didn't, and that surcharge stays attached to your premium for the rest of your life. Real numbers make this clear. A 2-year delay without a qualifying excuse triggers a 20% penalty, which at the 2026 rate means paying $243.48 per month instead of $202.90. Stretch that delay to 7 years, and the penalty hits 70%, pushing your monthly bill to $344.93 every single month until you're no longer on Medicare. That penalty never expires and never gets forgiven. If you're feeling overwhelmed by all these enrollment rules and deadlines, the State Health Insurance Assistance Program offers free one-on-one counseling to help you navigate Medicare decisions. Every state has SHIP counselors who can walk you through your options without trying to sell you anything. Beyond the premium increases, 2026 delivered some genuinely useful new benefits worth knowing about. January 1st marked the date when the first batch of negotiated drug prices under the Inflation Reduction Act went into effect. 10 medications covering diabetes, heart disease, cancer, blood clots, Autoimmune conditions and chronic kidney disease now carry negotiated prices, and the list includes heavily prescribed names like Eliquis, Jardiance, Xarelto, and Enbrel. Discounts range from 38 to 79% off the 2023 list prices, which CMS estimates will save beneficiaries $1.5 billion per year in out-of-pocket costs. 15 more drugs entered the negotiation pipeline in 2025, with those lower prices arriving in 2027. The Part D out-of-pocket cap ticked up slightly to $2,100 for 2026, and the $35 monthly insulin cap remains in place for both Part D and Part B. Telehealth access nearly vanished in October 2025 when a government shutdown caused Medicare's telehealth flexibilities to briefly lapse, but the Consolidated Appropriations Act of 2026 restored and extended them through December 20. Patients can receive telehealth from home with no geographic restrictions and use audio-only visits for a range of services. Several of these provisions have now become permanent, including behavioral and mental health telehealth from home and audio-only behavioral health visits, which removes the uncertainty that hung over these services for years. One significant addition comes mid-2026, when Medicare Part D begins covering GLP-1 drugs like Ozempic and Mounjaro for diabetes treatment, and Wegovy for cardiovascular risk reduction, with expanded obesity coverage through the new generous pilot program. Qualifying enrollees can access these medications at $50 per month, opening the door to treatments that were previously out of reach for many Medicare beneficiaries. Even with both Part A and Part B working together, original Medicare leaves some noticeable holes. Routine dental, meaning cleanings, fillings, extractions, and dentures, falls outside the program. Routine vision gets excluded too, covering neither eyeglasses nor contact lenses, nor standard eye exams. Hearing aids and routine hearing exams stay off the list as well. Long-term custodial care, cosmetic surgery, routine foot care, and care outside the United States all remain your responsibility. One gap stands out above the rest. Original Medicare carries no annual out-of-pocket maximum, which means that 20% Part B coinsurance has no ceiling. A serious illness or a complicated surgery can generate bills that just keep climbing with nothing to stop them. Two paths exist to close these gaps. Medigap plans, also called Medicare Supplement plans, work alongside original Medicare and cover deductibles, coinsurance, and copayments. Each plan is standardized by letter, so a Plan G from one company offers identical benefits to a Plan G from another, with only the price varying between them. They work at any provider in the country that accepts Medicare, which gives you complete geographic freedom. The enrollment window that matters most opens the month you turn 65 and join Part B, lasting 6 months, because during that stretch, insurers cannot deny you or charge more based on your health. After that window closes, medical underwriting can kick in. Medicare Advantage takes a different approach by bundling Part A, Part B, usually Part D, and often dental, vision, and hearing into a single plan from a private insurer, frequently at no extra monthly premium. The trade-off involves network restrictions and prior authorization requirements, but Advantage plans include something original Medicare lacks entirely, an annual out-of-pocket maximum. Around 54% of eligible Medicare beneficiaries now enroll in Medicare Advantage as of 2026, which shows how many people have chosen that route. So when it comes to Part A versus Part B, the answer for nearly everyone is that you need both of them working together. Part A shields you from the financial weight of hospital stays, and Part B handles the doctor visits, preventive screenings, and outpatient treatments that fill your actual day-to-day medical life. They were designed as two halves of one system, and they still function that way. Looking ahead, the Medicare Part A Trust Fund faces a projected shortfall by 2033, which means current workers and future retirees need to stay informed about potential changes to the program. This projected depletion could affect future benefit payments if Congress doesn't take action to shore up the trust fund. If one thing sticks with you from this video, let it be the enrollment timeline. Your initial enrollment period matters more than almost any other Medicare decision you'll face. That Part B late penalty, 10% for every year of delay attached to your premium for life, ranks among the most expensive mistakes in all of retirement planning. Qualifying employer coverage protects you from it. Without that coverage, signing up on time becomes non-negotiable. Medicare has served Americans for over 60 years now, growing from those first 19 million enrollees in 1966 to more than 67 million today. The program still won't cover dental, vision, or hearing under original Medicare, and the Part A Trust Fund faces that projected shortfall by 20. But between negotiated drug prices, expanded telehealth through 2027, and new GLP-1 coverage arriving mid-year, 2026 is delivering real value to anyone paying attention. If this helped you understand your coverage better, go ahead and subscribe and drop your biggest Medicare question in the comments, because we read every single one. Take care of yourselves.